1 sec. There we go.
Can I turn my camera off while Chris is speaking?
Yeah, that's fine. So welcome. We have a few people on. Thank you for joining us. I realize we're starting a bit earlier than normal. So thank you for paying attention to our start time. We'll give it maybe another 1 minute or so, and then we'll get started.
Yeah, that's fine.
One of our presenters is busy and important and needs to be going to places.
It has a night shift.
Yeah. Yeah, we'll give it another minute or so.
How can you see the attendees, Vicky?
So if you just click on the people.
Oh, okay, fine.
There. But yeah.
Yeah, people are joining.
Perfect. But yes, I suspect we might get an influx around 7 because unfortunately that's just when every week we've just run out. So
also I feel like if people have like, you know, lectures and stuff, sometimes it's just easier for them to join at 7, isn't it?
But what's really good is we'll record these lectures and people can access them afterwards. So your teaching will still be spread across
knowledge lives on.
Lives
on.
Yeah.
Well, anyway, I think we'll just introduce ourselves, I guess, in the meantime. Yeah. So I'm Chris. I'm a doctor at Royal Sussex County Hospital in Brighton. And then M is my friend. So we're both friends.
Hi, I'm Emily. Oh, no, sorry.
Sorry.
Hi, I'm Emily. I'm a doctor at Eastbourne Hospital. I work with Vicky.
Yes.
And I'm currently on ENT at the moment.
Oh, my.
Yes, I'm Vicky. You might have seen me in some of the previous sessions. I'm also part of the committee of MedTech teaching. So yeah, thanks to Chris and Emily for joining today to teach us some ENT and dermatology. So I think in the interest of time, let's get started. And like I said before, this session is going to be recorded and be uploaded to our Medal page, our YouTube, our website. So fear not, if you have friends that want to attend the session but can't attend at 6:30, that's okay. We've got it covered. So let's make a start then. So just a little bit of background about the organisation. So the overall organisation is called MedTech Teaching. This final series is called Thursday 15, but it's not just for final year students. Obviously, that's the aim, but it's very relevant for other year groups too, as you're going to cover these topics in all your exams at any stage, really. The concept is meant to be sort of 10 to 15 minutes of timed MCQs. And in this session, we're going to spread it out throughout the session. So instead of doing them all at the beginning, we're going to do it throughout the session. And we'll get some data on whether you prefer that or not at the end. But I think it will just make things go a little bit quicker. And we'll make sure to cover the answers and give you a bit of background knowledge about why the answers were or weren't correct in the MCQs. And then in terms of future sessions, we mainly run them on Thursdays. However, we've got some coming up on the Tuesdays. For example, next Tuesday, we've got GI, and next Thursday, we've got mental health. And you can find recordings on these sessions, like I said, on Medal, YouTube, and our website, and we'll provide links to those at the end of the session. So I will hand over to Chris now to make a start on the dermatology section. So yeah, take it away and just let me know whenever to change the slides, all right?
Okay, thanks so much, Vicky, for that intro and for hosting this. So if you just, go to the next one. So this would be our format. And basically what we'll cover are some of these ILOs. We won't cover everything, but we have basically given you sort of some questions that will kind of, blanket a few more high yield topics, maybe some things that you haven't seen before in dermatology that could come on your exam. Okay, so if we go to the next slide. And then the first question. So how we'll run this one is if I'll read the question out to you, and then the options as well. And then if you can just sort of write down the answers or put them in the chat box, and then we'll go through the answer after each question. So for this first question, a 25-year-old male with suspected tonsillitis presents to the emergency department following treatment with 5 days of oral amoxicillin given to him by his GP. He presents with the rash shown below. Now, I know he doesn't look 25 in this picture, so just ignore that. But if we go to the next slide, so basically, we're going to ask what's the most likely underlying cause of his rash. So A, is it HIV-associated macular papular exanthem? B, is it due to treatment of Epstein-Barr virus with amoxicillin? C, is it urticaria? Is it a photodermatosis, or is it guttate psoriasis? So if you guys just put your answer in the chat, I'll give you like a minute to answer the question. And then let us know. And Vicky, it might be best if you go back to the other slide for a sec. I think just because they can't see the picture, is that all right?
We've got one answer in the chat already, but we'll give people another few minutes. Sorry, a few seconds to answer.
Yeah, so if you remember, A was HIV-associated macular papular exanthem, B was Epstein-Barr, I believe C was urticaria, yeah, D photodermatosis, or E guttate psoriasis. Okay. So
I'll keep it on the slide for the moment. Let me know if you want me to switch back.
That's okay, yeah, thanks. Is everyone happy with that answer? So Norzia said B. If anybody else wants to put their answer in the chat, they can. But if we go to the next slide. Yeah, so the answer was B, that is correct. So basically, this is quite a common question. When I was in medical school, we'd get asked this quite often. So in this case, when you treat somebody with glandular fever with amoxicillin specifically, you usually get a sort of non-specific drug rash. That's benign in nature, so it's not actually going to be life-threatening and doesn't require any treatment. The only thing you can offer them usually is an emollient, like 50-50 ointment, or some like Secaban or something. But like there's no need for steroid or anything like that. It usually self-resolves. If we have a look at the other options, C, urticaria, this doesn't sort of present like an urticarial rash. You usually see wheals, which are basically raised macular lesions with no overlying pigmentary changes, but they usually are erythematous. And they're annular. An annular basically means that they are shaped sort of like a circle, but like squiggly. So if you think of like a squiggly circle, that's usually like what an annular lesion is. Photodermatosis doesn't really align with the stem. It's usually triggered by exposure to the sun. And then guttate psoriasis is sort of that raindrop-like pattern all over the body, and that usually happens after the infection has resolved. So it usually comes on 1 to 2 weeks following the infection, and the patient usually feels completely well in themselves. And that's also something that doesn't usually require treatment. Okay, if we go to the next slide as well, Vicky. Yeah, so basically I just put the same explanation here. So mobiliform drug eruption that occurs when glandular fever or Epstein-Barr virus treated with amoxicillin. It's benign and it'll self-resolve. You usually discontinue treatment with amoxicillin. You can maybe even get them a monospot test, but that would not be something that's absolutely necessary. Okay, if you go to the next slide as well, I've just put here sort of some drug reaction differentials. So drug reactions that are absent of systemic symptoms are usually far more sort of common and less worrying in a clinical setting. So you've got drug-induced urticaria, which everybody knows is sort of got a bit of a skin rash. When I took that medicine, you usually just discontinue that medicine and swap to a more suitable medicine. A mobiliform drug eruption is usually like sort of widespread, but doesn't actually cause any systemic symptoms or upset. I mean, acne, you can get acne from some drugs as well. That evidence for that's kind of shaky. And then a fixed drug eruption is usually when you get sort of one little spot on your body blister, and that can be sort of a fixed drug reaction. It's usually also non-life-threatening. When you want to be concerned about a drug reaction, are sort of obviously cases like anaphylaxis, where you get sort of hemodynamic instability, airway distress, and we all know the management for that's usually IM adrenaline, and then aggressive fluid resuscitation. The guidelines now also recommend that you give them antihistamines and steroids, but not in the acute phase. They actually don't help very much in the acute phase. Okay, so the guidelines basically recommend the repeat adrenaline shots and the fluid resus in the acute phase. If you've never heard of DRESS, it basically is sort of a drug reaction with erythema and systemic symptoms. So it's, I mean, name's a bit silly, but it basically is a non-specific drug reaction that causes hemodynamic instability. AGEP is basically acute granulomatous reaction with pustules. So they all just present a little bit differently, but they are sort of along this of the same family. And then Stevens-Johnson syndrome, or SJS, and TEN involve the sort of sloughing of the epidermis. And those are obviously concerning because homeostasis is affected and temperature regulation is also affected, which can lead to sort of cardiac instability as well, and ECG changes associated with hypothermia, like J waves and things like that. You don't have to get into it, but you just need to be aware that they can happen, okay? And so in this table is just good at differentiating when something is sort of life-threatening, when something is not life-threatening in terms of drug reactions. All right, if we can go to the next slide as well, to the next question. So in this question, we've got a 21-year-old woman who presents to the emergency department following a burn from a corrosive chemical. In the initial stages following insult to the skin, the patient irrigated the wound with which of the following substances, causing worsening of the chemical reaction? So A, potassium chloride solution, B, mineral oil, C, calcium gluconate gel, D, sodium chloride 0.9% solution, or E, water. And you can see in this photo that the patient basically has had some damage to the epidermis and the dermis, it looks like. They've got a bit of a hematoma underneath the skin, and they've had some death of the top layer of skin. And you can see that on the fingertip, that's now dead and will probably fall off soon. Okay, so if you guys just put in the chat what you think it might be. Does anyone want to guess, maybe? Just like no answer is a silly answer. I'll explain why it is what it is after. So just if anyone wants to guess one of them, if you're not sure. Okay, so we've got A. Anyone else want to guess before we go through it? Okay, let's, Vicky, can we go to the next slide? Okay, so basically this is actually a really good one to know. I know we don't get taught lots about burns, but if someone works in sort of a chemical plant and they're interacting with sort of this solutions that are salts of metals, right? So if you have a salt that's basically involving a metal like lithium, magnesium, potassium, sodium, and they're quite reactive to sort of the air and water as well. They are usually like burns or injuries you sustain from them are worsened by irrigation with water because it actually further lowers the pH and can sort of increase the rate of reaction if you remember chemistry. So in this case, water will actually donate its H+ ion, okay? and cause worsening of the reaction. So what you want to do is sort of snuff it out in a way and prevent it from reacting further. So mineral. Oh, can we do the slide during the question one stem? Let me just finish explaining this bit first. So in this case, if you get burned by a corrosive substance, that's a salt of a metal like lithium, magnesium, or potassium, usually actually want to irrigate it with a mineral oil. Okay, because it stops the oxidative process from continuing. So that's a chemical reaction. Do you want to go back to the first slide, Vicky, for question one? Sorry.
We'll give it a few seconds.
Yeah, is that okay, Shayna?
And we'll record the session, so you can always head back at the end. Is that okay?
Yeah.
Brilliant.
Okay, so let's go back to the burns bit because we're not finished. Okay, so yeah, so in this case as well, let's know about skin burns. It's actually quite sort of simple to understand, but in a first degree burn, usually the epidermis is the only layer that's affected. Okay, now what tends to happen with that, right, is that you get the sort of loss of the top layer of skin, and it can be quite painful. Okay, because you've got lots of nerve endings within the epidermis and dermis, right? When a skin burn goes down to the dermis, it's also painful, and that's your burn. When you've got a skin burn that's gone down to the dermis, you may not get full recovery of the epidermis. It just depends on sort of your ability to heal. Some people scar more than others, etc. And we're all a bit different genetically. When you get a third degree burn, these burns tend to go down all the way to the hypodermis or the subcutaneous tissue. When you get a third degree burn, it actually tends to be quite painless because you've lost that layer of the dermis where most of the nerve endings lie. And when you get a full thickness burn like that, then there's sort of, higher risk for infection, etc. And it usually has to be managed in a burns unit. You may need things like skin grafting. But another thing to remember for burns is that if you use, if you've got a patient with a burn and it covers a lot of their body surface area, remember that they're going to require more fluids and things like that when they come into sort of an emergency department setting, or if they come in as a trauma. So you're going to need to use the Parkland formula to calculate their fluid requirements, because it will be much higher than someone who's got all of their sort of skin intact. And if you guys have MD Calc, that's a really good app, and it's got all those formulas on it. Essentially, you sort of measure your body's surface area in nines. So it's like 9 for the front of the arms, 9 for the thighs, things like that. But if you have a look, you can see, the sort of percentages that they use to divide the total body surface area up into. All right. Okay. So if we go to the next slide. So question 3 is, we've got a 42-year-old female presents the GP with a 12-week history of discomfort at the base of the nail of her left thumb, an expanding white plaque on the nail of the affected finger. You can see that easily in the photo. Based on the presentation, what are the following treatments first line? So we've got cyclopyrox, I think that's how you say it, which is antifungal nail lacquer, right? It's a nail polish, basically. Oral terbinafine. Are we going to do a medical nail avulsion and remove her entire nail? Are we going to give no treatment and just say it'll resolve on its own? Or are we going to give her something like oral ivermectin? Okay. Maybe, Vicky, if you want to go back to this stem and then come back to this, just so they can see.
I'll keep this on for about 10 seconds, and I'll move on to the answer options as well.
And in this question, I think it's really important to just have a look at where the actual lesion is. That will sort of determine which management's best.
Fine, and now I'm just going to move on to the answer options now.
Yeah.
There we go. Let me know if we want to switch back.
Anybody have any ideas what they might pick?
I'll quickly go back to the
So we've got B. Yeah. So we've got yeah, 1 for B. Anybody else? Okay, why don't we just go to the answer, Vicky? It's fine. Okay, yeah, so actually B is correct. Really good job. In this case, the proximal nail folds involved, as you can see, and that's going to affect the nail matrix. Well, the nail matrix is basically where the nail grows from, right? So the nail grows from the nail fold matrix. So in this patient, you're going to want to treat them with oral therapy because this is unlikely to resolve with something like nail lacquer. Just because you can see as well with the fact that it's raised means that it's already invaded so sort of far in that it's probably causing localized inflammation. And antifungals don't really work very well topically unless there's sort of constant clipping of the nail. So what they even tell you to do when you have a fungal nail problem and you're using something like a nail lacquer is you've got to roughen the surface of the nail to try and increase penetrance of the actual drug, like topical drug, topical solution. They don't tend to work very well, and then you usually have to treat that nail for up to 3 months. Okay, so it may be a viable option in those with onychomycosis, which I put there. But if it affects the distal nail plate, then you have to apply it at least a few times per week. Usually leave it quite a long time, so it's best to apply it at night, and then it's usually used for a really long time, like 3 months. So you'll be battling that fungal nail infection for, a while. In this case, I would give this patient an oral medicine for at least 2 weeks or so, see if it helps, and then you might give it for a further 2 weeks until until you're sure that the infection is up. Okay. Okay, go to the next slide, please. Right, so this is just nail disorders, right, in dermatology patients. So it's really, really simple to remember, but just remember nail pits or depression, sort of odd markings on the nails, they're usually signs of an autoimmune process going on. So in that second box on the left, you can see nail pits or depressions usually are a sign of psoriasis, alopecia, or a connective tissue disease. So you'd want to be concerned about something else. If you find your patient says, I've got loads of pits in my nails, they grow at odd rates, or they tend to just fall off on their own, things like that. I'd be more suspicious of an autoimmune cause. Horizontal ridging can be a sign of zinc deficiency or diabetes as well. And yellowing of the nail too, that can be a sign of diabetes. Usually because the blood supply is poor to the sort of distal bit of the nail, and then it starts to turn yellow just from oxidization, like with the air, and because the blood supply is poor, right? So it can, and both nail can also be a sign of fungus, but it's not a sign of having a fungal nail infection. Having brittle nails may also signal poor nutrition, low vitamin A or vitamin C, things like scurvy and stuff like that, or thyroid disease. Okay, so those are just something that you should some things that you should be aware of. Having a dark mark in the nail could be a melanonychia, which can be completely benign, or if it extends definitely from the actual base of a nail, you'd want to suspect melanoma. Melanomas are usually lentiginous. Acral means that they occur on these parts of the body, so the fingertips and things like the toes. And they are usually sort of the ones that are most easily missed. And they are more common in people of sort of tones. Okay? All right, so if we move on to the next slide. So for this question, we've got a 66-year-old male who presents to derm clinic for follow-up on his pre-existing chronic condition, bullous pemphigoid. He currently takes systemic therapy in the form of oral prednisolone, which added in as adjunctive therapies in order to allow adequate steroid taper. So if you remember the sort of pathophysiology of bullous pemphigoid, it's a chronic condition. tense blisters, and it usually occurs in the older age group. Okay, it can be quite resistant to treatment at times, and it can sort of vary in its degree of severity. So some patients have few lesions, very tolerable, and some patients have lots of lesions, lots of itching, very intolerable, very difficult to treat. In this case, we've got A as an option, oral doxycycline and topical clobetasol butyrate. B, cool tar preparation. C, oral erythromycin and dapsone. D, rituximab, or E, methylprednisolone infusion. Now, when you're thinking about the answer for this question too, it's really important to sort of read the stem. So we're thinking about a steroid taper, so we won't necessarily want to increase the current amount of steroids that he's on. And then when you guys are ready, you can just put the answer in the chat. Also, guys, just one thing I want to say, sorry, that should be clobetasol propionate, not butyrate. So if anybody knows, apologies for that. But it is clobetasol, not clobetasone. Does anyone know which answer might be correct? No? Okay, so basically, in this case, if we just go to the next slide. Yeah, so sorry, this should be oral doxycycline and topical clobetasol propionate. That's Dermavate cream, so topical, very strong topical corticosteroid. In this case, so doxycycline is a great agent. That's, a tetracycline antibiotic that's used for prolonged periods in dermatology, in particular for anti-inflammatory effects, especially in some autoimmune conditions. All right. And then topical steroids such as clobetasol allow the patient to sort of reduce the amount of systemic steroid therapy they might be taking. And if you remember the effects of systemic steroid therapy, so you've got mood changes, weight gain, you get cushioning items, so increased dorso, cervical fat pad. You can get increased, abdominal striae, easy bruising, muscle wasting, things like that. So skin thinning. So if you've got to think of sort of effects of steroids long term, just think of sort of somebody with a Cushingoid syndrome, and then you'll remember them. Yeah, if we can go to the next slide, Vicky. So just to go through some blistering disorders and some of the most common ones you'll come across probably in your exams. So we've got bullous pemphigoid, which is something that they always ask you about. As I said before, it's common in older people, and it rarely ever involves mucous membranes. It usually involves the forearms, the legs, the abdomen, but it does not usually involve the mouth, the eyes, the genitalia, anything like that. Okay, whereas something like pemphigus vulgaris, which is also an autoimmune blistering disorder, but with flaccid blisters that are more easily popped, occurs in a sort of a younger population, and it does usually involve the mucous membrane. If you think about the type of blistering that occurs, it has to do with autoantibodies against the junctional proteins within the skin. So like, if you look at the table here, it says intraepidermal blistering. So that means that within the actual epidermis, there's fluid leak. And then you get these sort of really flaccid blisters forming on the top layer of the skin, whereas the junctional protein dysfunction in bullous pemphigoid is within the lower layers, deeper layers. So the fluid leak comes from below, and then the top layer of skin is intact. So you get these tense and firm blisters, right? And then if you look at Nikolsky's sign is basically, can the blisters be ruptured with horizontal tangential pressure? So if I had a blister like this, can I push across and pop them? And in pemphigus vulgaris, which is a more serious condition than bullous pemphigoid, that usually happens, right? So you usually get quite a lot of abraded and broken skin, easy sites for opportunistic infection, things like staph, bacteria. Okay, whereas in bullous pemphigoid, you don't often get that. So what they might say as a sort of positive is that in bullous pemphigoid, you can pop the blisters, drain them, but like leave the top layer of skin intact. Whereas in a disease like pemphigus vulgaris, they may pop on their own from simply laying back or sort of, doing activities of daily life. And then you get like an opportunistic infection that way. And pemphigus vulgaris has a higher mortality rate, higher ITU admission rate, things like that. That's how they differ in general. So if you didn't know about them, it's a good sort of just quick overview. And I think that's all you really need to know for your final exams. Anyway, we can move on to the next question. Question. So question 5, we've got a 2-year-old male who presents to the ED regarding strange blistering lesions on the plantar surface of his left foot. It has been slowly becoming larger over the past 3 days. What's the most likely condition? Does anybody know what this is? You got a gold star if you know what it is. But I think if you look at the actual image, you'll see that it's on a frictional surface. So he's only got blister on the underside of his feet. Okay, Vicky, if you move to the next slide, just see the options. So is it bullous pemphigoid? Is it hand, foot, and mouth disease? Is it epidermolysis bullosa acquisita, epidermolysis bullosa, or myasthenia gravis?
I'll quickly go back to the stem as well, just in case.
Yeah. So 2-year-old male presents to ED, strange blisters on the underside of his feet. They're slowly becoming larger. Anyone? Okay, so if anyone wants to put what they think it might be in the chat, even if it's a guess, it's okay. So you got B, hand, foot, and mouth disease. Anyone else want to say anything? No, okay. So if we go on to the answer, so in this case, this is actually a blistering disorder that's not usually discussed in medical school. I know dermatology can be a bit remote for a lot of us just because we don't get much exposure to it. But in this case, it's a really common, not common, but sort of, if you had a look at a kid in peds ED and you saw this, you might think, okay, this could be, one of my top differentials. Basically, it's a congenital sort of inherited condition. It's caused by the ill functioning of the junctional protein. So it's quite similar to sort of the other blistering disorders, and that's how they all come about. There's this dysfunction of the junctional proteins, which allows the interstitial fluid to leak into the skin, right? And this causes blisters at the sites of friction. So palms and soles are most commonly affected. So if you think that you see a toddler with, the sort of blisters, palms, forearms, soles of the feet, things like that, places that they're sort of using their body to lean and press and, aid in mobility as they learn to walk and things like that, it might be worth thinking, could this be epidermolysis bullosa? It can be quite a debilitating condition, but basically, you refer them on to secondary care, they seek specialist advice, and then get the help that they need. It can also occur in adults, and that's called epidermolysis bullosa acquisita. So if you look at the name in Latin, it basically just means the same thing, but acquisita as in acquired. So it's not present at birth, but it appears later on. And it's an autoimmune disease, and it's sort of similar in its etiology and pathophysiology. Okay, so let's move on to the next slide, if that's all right. Yeah, so it's just a quick osmosis, stolen from osmosis summary, but it basically is a skin breakdown that causes blisters. If you look at the name, they break it down there. So epidermal skin, lysis equals breakdown, bullosa blisters, right? It's a rare condition, but it's an inherited group of disorders that causes erosions after minor trauma. That's because of fragile epithelial tissue. And it can affect mucous membranes and nails as well, right? So you get mutations in the keratin, desmosomes, junctional proteins, things like that. And obviously the sort of genetic inheritance pattern will determine the severity of disease. All right, okay, so can we move on to the next slide? Okay, so question 6. This is a question about acne. So 2 failed treatment cycles, so 2 times 3 months, right? 2 bouts of 3 months each with oral tetracycline in a cystic acne vulgaris patient. Which of the following options is the next best step in management of her condition? So are we going to refer them to secondary care for commencement of isotretinoin therapy? Are we going to prescribe topical clindamycin and benzoyl peroxide? Are we going to give them a topical retinoid only? Are we going to advise them phototherapy? Or are we going to give them something like topical azelaic acid with topical spironolactone? And I'll explain after what each of these treatments might be useful for. So if you look at the NICE acne guidelines, it should be pretty simple to figure out. Anybody want to give a guess in the chat? So if you think about this question, which therapies, what I would do is narrow it down by which therapies they likely have already tried and which therapy they might be suitable for next, and then you get the answer. Does anybody want to guess? Okay, Vicky, do you mind going on to the next slide? Okay, so in this case, if you look at the guidelines for acne treatment, basically when someone presents with acne and it's non-complicated, so it's not cystic acne or something like acne fulminans, which is common in people who use steroids. So if you think, gym goer using anabolic steroids could be something like a cystic acneic disease like acne fulminans, right? It's just sort of acne normal, typical acne. You start off with a topical antibiotic like clindamycin and benzoyl peroxide. If that doesn't usually work, you usually recommend a topical retinoid. So you'd add in adapalene, tretinoin, tazarotene, something like that, plus a topical antibiotic, right? Or it'll be a topical retinoid plus benzoyl peroxide, like whichever. That's the commonly known topical treatment called Epiduo. That one's adapalene plus benzoyl peroxide. You've got a lot of others. You've got different gel, things like that, Retin-A, stuff like that. So they all, if you look them up, you can find loads of them online. But that's what they usually recommend first. If that's not controlling the sort of current lesions and preventing new ones from coming up, then you usually add in an oral antibiotic. So you're going to give limocycline, oxytetracycline, sometimes doxycycline or erythromycin. And then that's usually prescribed as a course of 3 months. And what they recommend is 2 cycles of that. So 2 times 3 months equals a total of 6 months. And then you get basically some relief, hopefully. It can sort of mess your gut health up. So it's not necessarily something you want to continue for a very long time. And then obviously prolonged antibiotic use leads to antibiotic resistance, right? So the bacterial burden of your skin might be something that's contributing to your acne. And then usually those patients respond well to oral antibiotics. If that's not the cause, and it might be sort of more due to testosterone, increased sebum production, things like that, then it doesn't usually work as well. So sometimes you need oral isotretinoin therapy, which is commonly known as Roaccutane or Accutane, which people sort of talk about it on YouTube a lot. But it's a dose-adjusted lipophilic drug. So it basically is stored in your fat cells because it's vitamin A, it's oral vitamin A, high dose. And you basically get sort of a drying effect, a reduction in the number of sebaceous glands within the skin. And then that usually, if there are less receptors for the testosterone to act on those sebaceous glands, because they've sort of been reduced in number, and you get a bit less oil production and reduction in the number of acne lesions that are going to come up. Okay, so yeah, so basically in this case, this kid has tried topicals. So we've exhausted topicals, and then we tried oral antibiotics that haven't worked. So it'd be appropriate now to refer for Roaccutane. Okay. The other options, if you just go back one slide, Vicky, sorry. The other options, as we discussed, are topical therapies that so B and C. D, phototherapy, not usually helpful in acne. And then E, topical azelaic acid with topical spironolactone might be prescribed for sort of a female who has hormonal acne or acne that's sort of more in line with her sort of menstrual cycle, etc. So in this case, you want to move straight on to referral to secondary care. Okay, yeah, if we can go 2 slides ahead, Vicky, thanks. I think I just put this really good graphic here, which shows how acne treatment might work. And they do all these things like a failure at 3 months. So it's actually really helpful to see what might be used next, right? And also it depends. If you've got a patient who's come in as very severe acne and there are loads of nodules, it may cover their body as well. It might be worth saying, look, I think we should start with an oral therapy first. But it's all sort of patient specific, okay? If we move on to the next slide. Right, oh. Oh no.
What?
Okay. So I think you guys saw the answer, but hopefully you didn't. Anyway, so this question, we've got a 65-year-old man who presents at derm clinic with a rapidly expanding lesion on the right side of his abdomen. Which of the following parameters is most useful in determining mortality and potential morbidity of this condition? So we've got degree of evolution, we've got Breslow thickness, mitotic indices, the size of the lesion, or his own comorbidities as a patient. What do you guys think? Any ideas, anyone? This is our last question before you move on to ENT with Emily. Does anyone want to give it a guess? Okay, so in this case, if you look at the answers, actually, they're all sort of important in determining sort of the, I guess, how aggressive of a skin cancer this would be. So we do want to look at degree of evolution as part of the ABCDE criteria. You basically do want to look at mitotic indices when they've sort of looked at the lesion when they biopsied it and looked at it under the slide in the histopathology lab. Size of a lesion can sort of determine, whether this might be something we really should worry about or not. And obviously the patient's own comorbidities would be sort of useful in knowing how they might fare with immunotherapy or chemotherapy or radiotherapy, right? So in this case, though, the most important prognostic factor would be breast thickness. And if you go to the next slide, please, thanks, Vicky. This graphic basically shows how you might grade a melanoma. So one, breast thickness has, in dermatology long been the most important prognostic factor in determining the mortality and morbidity of a patient with a melanoma. So it's a measure of the vertical depth of the lesion in one plane only. And basically, lesions with greater vertical depth are more likely to metastasize. And the reason that is because the dermis, you can't see the slides, oh no. Maybe log in and log out and log back in. If anyone else can't see them, please speak up. But yeah, so basically breast thickness has to do with the depth of the actual lesion. So the closer the lesion is to the dermis and obviously the vasculature, the more sorry, I think Vicky, do you mind just having a look at the chat? It says slides.
Yes, I'm seeing that. I'm not sure why, because we're loading it. Let me just reload. Is that better?
Oh, it's fixed, apparently.
Oh, fixed. Okay.
Yeah, I think it's fixed. Okay, so I'm just gonna say that. So in this case, right, melanoma into the vasculature, it's more likely to metastasize. When it's more likely to metastasize, obviously you've got a worse prognosis, right? So if you have a lesion that is sort of 4 millimeters deep, you've sort of, gotten the worst grade in terms of, TNM staging. You got basically stage 4. So stage 4 melanoma, it's very deep down. Breast thickness is, at its maximum. And we're now concerned about metastasis. You want to do things like staging CT, CAP, and things like that to have a look at if there are any other lesions anywhere else. And melanoma in particular has one of the highest mortality rates of any cancer because one, it responds very poorly to chemotherapy. It responds better to immunotherapies, which we only now have sort of discovered recently. And also it metastasizes to places that are difficult to treat, such as the small bowel and the brain. Okay, so in this case, if you have a look at the image, you can see that a melanoma less than 0.8 millimeters is not worrying, it's a melanoma in situ. And then you've got stage 2, 3, and 4. So depth basically determines that. And you can have a look line basically at the kind of, ranges, but it's basically 1 millimeter to I think 1.5. You just keep going from there, 1.5 to 2, 2 to 3, etc. So it's pretty self-explanatory. Any meters is just sort of put as stage 4 and is kind of highly concerning. All right. I think the next for this one is Oh yeah, there's just the image references. But anyway, thank you guys so much for listening. I do have to go to my shift now, but yeah, let Em take over.
Thanks, Chris. And just a welcome to those who've joined us. I know we've started a bit earlier this session, so we've got a few more people who've come in halfway through the sessions. We're going to start the ENT section now. Let me know if there are any issues with the slides. Sorry if you couldn't see them properly, but hopefully I've just reloaded them, so hopefully that's worked.
Okay.
Yeah, I'll let
All
you
right.
take it away.
Bye, though.
Thanks, Chris.
Bye.
Okay, perfect. So yeah, just going to go through some ENT questions. Obviously, can't cover the whole syllabus, but I just chose some ones just to get the hot topics. So yeah, next slide, please, Bex. Okay, sorry, you can't see them that well because of the purple. But the first question is a 22-year-old male with a 5-day history of sore throat and poor oral intake due to pain. On examination, the patient is febrile and speaking with a hot potato voice and has trismus of the jaw. What is the most likely diagnosis? So A is glandular fever, B is bilateral acute tonsillitis, C is epiglottitis, D is quinsy, and E is pharyngitis. Yeah. Yes, you guys can put your answers in the chat or just do them in your head, I don't mind. Okay, cool. So most people thinking it's D. So if we go to the next slide, please. So yeah, the key parts of this question kind of distinguish it as being a quinsy rather than a tonsillitis or just a glandular fever. Is just, well, one of the key things is like the trismus of the jaw. So that basically just means that like the patient won't be able to open their mouth fully, and that's like quite a high diagnostic indicator that somebody has a quinsy. Just having a sore throat and like inflammation and pus on the tonsils doesn't necessarily mean that somebody has a quinsy. Next slide, please. So yeah, it's a clinical diagnosis. And usually it starts with someone just having tonsillitis. They might have like pus on their tonsils. They might have been given antibiotics by the GP. But basically, pus collects in the peritonsillar space. So from the picture, you can see like normally you have like the pharyngeal arches, and they should be symmetrical. With somebody in a quinsy, when you look in their mouth, one pharyngeal arch will be kind of displaced more medially than the other one. That's shown by like the arrow in the picture. So it's not the tonsils themselves will be enlarged, but it's actually kind of the area around the tonsils that basically that's where the abscess is. And the reason that people get trismus is due to the pus irritates the muscles of mastication. So it's the pterygoid muscle generally, which is like spasming. So that's why they can't open their mouth. Usually they say like kind of 3-finger thickness. So if you can't, like, if you were to kind of measure with your fingers, if you ask someone to open their mouth, then that's like a very key one. Boys are more likely, or males are more likely to get quinsies. So that's like another risk factor from the stem of the question. And then hot potato voice is basically just like, it sounds like as if someone's got like, their voice will sound quite distinctly like different from normal. It's like not necessarily like when someone has a whispering voice with a sore throat, like it's like it sounds like they've literally got something hot in their mouth. But yeah, so the main thing with these patients is that they're going to need to be admitted. So we're going to admit them, going to start IV antibiotics. Usually we give benzyl penicillin is the first line. And then they get a stat dose of dexamethasone. And also like analgesia is really important. So like patients generally with the especially with the trismus aren't able to eat and drink, so that's kind of the main reason for admission. And basically the kind of definitive management is that they need to it needs to be aspirated. So that would just involve like sticking a needle into kind of like the most fluctuant point, and kind of trying to drain the pus. So yeah, that's a quinsy. Next slide, please. Let me know if I'm speaking too fast or going too fast. But yeah, next question. This is a 54-year-old lady presenting with sudden onset hearing loss in her left ear. She also has tinnitus in her left ear, no pain or discharge. And on examination of her ear, it's normal in the canal, no tenderness of her external ear. She's Rinne's positive, and the Weber test lateralizes to the right side. What is the most appropriate immediate management? So A is urgent MRI head, B is pred for 2 weeks, C is amoxicillin for 10 days, and D, they've all
put them in the chat. Sorry, because
okay.
Cut on the slides, but I've just put them in the chat as well.
Okay, so D is watchful waiting, and then E is myringotomy within 2 weeks.
So we had one response before I put the other options in the chat. Okay. So Izzy's already answered this one.
Okay. Yeah, next slide, please, Vicky. Yeah, so this question, like the key bit of this question is the fact that it's immediate management. And yeah, the correct answer is prednisolone. If we go to the next slide, I will explain why. So this is just about kind of interpreting the Rinne and the Weber's test. Oh, shit.
Apologies, I think Emily might just had a bit of a technical issue there. I'm just going to check in with what is happening. She may or may not have lost her... I think she's lost her battery power. So give us 2 seconds. She's just getting her charger in. Apologies. And we'll restart where we were. Yeah, just give her a minute or so. Thanks everyone for bearing with. There, she's back.
Hi, sorry, am I back now? Sorry, I didn't know.
Yes, you're back. You're back.
Yeah, so just interpreting the Rinne and the Weber's test. So we're kind of trying to assess for like sensory neural hearing loss. That's like the key thing. Well, you're trying to differentiate between the two. So in a normal patient, and also in somebody with so air should be louder than bone. So that basically, so when with the Rinne's test, you hold it, you tap the tuning fork and you hold it by their ear, and then you place it on the bone, on the mastoid bone behind their ear. And in patients with sensory neural hearing loss, it will lateralize to the same side. And in conductive hearing loss, the bone will be louder. Sorry, I've just said it the wrong way around. bone will be louder than air if someone has conductive hearing loss, whereas air will be louder than bone if it's sensory neural hearing loss. So that's just a diagram to explain the Rinne and Weber's tests. next question. So with patients that present with like sudden onset hearing loss, it's kind of important to identify, like, first of all, you want to like rule out that they haven't had any like recent head trauma, no recent ear surgery, or like if they're systemically unwell, because you might need to rule out meningitis. But if you see somebody that's presenting with this, if it's in with like a very sudden onset hearing loss, the first line management is steroids. A lot of people, so on the first bit I've just talked through, like the different causes of sensory neural hearing loss. So obviously there's congenital, but here we're looking at acquired causes, and most causes of sensory neural hearing loss are idiopathic, so we don't really know exactly why that is, but we know that steroids can help to reduce the amount of hearing loss that somebody has. So yeah, we give prednisolone for 2 weeks. So that's like the immediate management. However, given that one of the other differentials for sudden onset hearing loss is acoustic neuroma, you want to refer somebody to ENT, and they'll have audiometry and tympanometry. And if that is confirms that they have sensory neural hearing loss, then they will need an MRI head. So that was why like MRI head is part of the management for sensory neural hearing loss, but it's not the immediate management. So yeah, acoustic neuroma is quite rare, but it's an important one to rule out. And sometimes like people might also present with facial nerve palsy. So that's like another thing to be aware of, because sometimes because the facial nerve is also runs in a very close proximity to the vestibular nerve. That's something else to be aware of. But yeah, basically high dose steroid and urgent ENT referral for somebody. So this could be someone that you see in GP, but then it gets referred to ENT. Yeah, next slide. Perfect. So this is a 67-year-old male with a background of hypertension, diabetes, and knee osteoarthritis. He presents with unilateral foul-smelling discharge and a 4-week history of gnawing ear pain. The pain is worse at night. What is the most likely causative organism? Yeah, if we go to the next slide. Perfect. So yeah, the key bits of this question that kind of might lead you to the diagnosis of necrotizing otitis externa would be the fact that it's an immunocompromised patient. So he's got type 2 diabetes, and kind of like the insidious onset. So the fact that it's kind of a longer history of the ear pain, and the fact that the ear pain is worse at night. Those are the kind of key suggestions that point towards the diagnosis of necrotizing otitis externa. So if we go to the next slide. So yeah, it's called malignant otitis externa or necrotizing otitis externa. It's not actually a malignancy. It's more just the fact that it's a complication of like classic otitis externa, but it occurs in immunocompromised patients, especially older patients. So sometimes people might have already been treated with antibiotics previously, and it just hasn't completely resolved. But it's really important to treat it very promptly, and they will need admission as it's potentially life-threatening. So first line, you want to start the antibiotics very promptly, but you're probably going to send some ear swabs for MCNS, as well as pathology of the, you get like granulation tissue inside the ear canal, and they may need further imaging to see if it's eroding the bones of the skull. So they will need extended antibiotics, usually for 6 weeks. So you want to kind of do like a septic screen as well, so like full blood count, Usinese, and like give them, they might need like fluid resuscitation, and like kind of like suctioning out any of the pus and debris inside the ear, and yeah, the combination is probably something like IV ceftriaxone. That would be the first line antibiotic, and they will need like close monitoring, and they might need to be discussed at kind of an MDT meeting, if there is like if there's bony involvement of the bones of the ear. Features that have worse prognosis for somebody with malignant otitis externa, they could have hearing loss as well associated. So if they have hearing loss, that's a poor prognostic feature. And so you might want to get kind of like baseline hearing tests. And also sometimes people, again, can present with facial nerve palsies. So that's another poor prognostic feature for malignant otitis externa. So yeah, that is everything for that question. Okay, question 4 is a 38-year-old female who recently underwent total thyroidectomy, so during the day, and the patient is complaining of fluctuant swelling over the incision site and is short of breath. You go to assess her. She has stridor and a drop in her SAT, so her SATs are 92% on air. What do we think is the most appropriate management? Cool, let's go to the next slide, please. Okay, so this question is kind of just about like identifying an unwell patient, given that she has stridor and drop in SATs. That's quite a severe presentation. So this is kind of just like trying to highlight the importance of like the A to E assessment. So in this situation, it looks like this patient has their airway is compromised. So if we go to the next slide. So this picture shows like what we might see in this case. So it's kind of like a swelling that is fluctuant, and patients might present with difficulty with breathings, stridor. So that's like the upper airway noise if someone has occlusion of that upper airway. And these patients can get unwell very quickly. So if you ever kind of have a nurse call you to see a post-thyroidectomy patient, then or like a post-op patient that they're saying they've got an airway problem, it's really important to go and assess them very quickly, because you might need to escalate it, and they might need to go back to theatres with the airway situation. Again, this is another thing to consider that you might be considering might be that sometimes people get like a seroma. So this patient is probably a hematoma, given it if it happens acutely, and they have an airway problem, it's likely to be a hematoma, whereas if it's kind of the next day or 2 days, it might be more likely to be a seroma, which is like the serous fluid leaking out. If we go to the next slide. So yeah, it's really important that if you see a patient that's like has stridor, low sats, then you're going to need to like probably like press the emergency buzzer, get as many people in to come and help you, put oxygen on the patient, sit the patient upright, and basically the acronym that they advise is the SCOOP. So you want to have to cut the stitches, open the skin and the muscles, and pack the wound. So the reason that the other like answers weren't correct was just that they're not the most like immediate management. The patient probably will have to go back to theatre, but given that they have an area problem, you're going to have to deal with that straight away. Yeah, that's all good. Okay, question 5. This is a 92-year-old male who takes apixaban for AF. He's had 1 hour of bleeding from his right nostril, not stopping with first aid measures. Where is the most likely source of bleeding?
We've got one answer in the chat so far.
Okay. Perfect. If we go to the next slide, please. So the correct answer is the anterior inferior septum. So that's like the middle of, inside the nose at the front, in the septum. So yeah, wrist. If I go to the next slide as well, please. This diagram shows Little's area, which is basically like the area which is very rich in blood supply. So most bleeding will be from that area of the nose. Obviously, there's lots of patients who are on apixaban or warfarin, so they're kind of more high risk patients. Often it's just like there isn't necessarily like an identifiable cause. People just have nosebleeds. But sometimes like nose picking can be a common one that people might not necessarily admit to. So generally they're anterior bleeds, but sometimes they can be posterior bleeds. So it's really important. Towards the back of the nose, so it's really important to look in the patient's mouth, just to see if you can see like any like trickling into the back of the throat. And so the first aid measures is to lean the patient forwards and to like pinch the like soft part of the nose, and you need to apply continuous pressure for 30 minutes. So that's like the first stage, and that generally like can be managed like in A&E or like by the patient. But if that doesn't work and they're still bleeding, then either you can try using like nasopore, which is basically like some dissolvable like porous things that you put up the nose. But some patients might need to insert a rapid rhino. I think I put a picture on the next page. Basically any patients that you have to put nasal packing in, so that would be the rapid rhino, then they would need to be admitted. So any patients who are like older and frailer, they'll need admitting, and anybody with nasal packing, so they just need to be monitored for 24 hours before we take the pack out. Generally, the pack for anterior bleeds will stop, but sometimes you might need to use a longer pack that reaches kind of up towards posterior bleeds. if someone is still bleeding with the packing, that might be more suggestive that they have a posterior bleed, so that they'll kind of need senior review. And if it's not stopping, then or if it is more of a posterior bleed that is stopped with the packing, they might need to go to be referred to be seen in clinic for sphenopalatine artery ligation. So yeah, anybody that has a nosebleed, on discharge after we've removed the packing, we give them Naceptin. And it's really important to ask about peanut allergies because it contains peanut oil. So you need to ask about allergies. And basically you just apply that twice a day for 7 days afterwards. And that just kind of helps to lubricate the area to like prevent further bleeds. And sometimes we also use cauterization. So that's just like using the silver nitrate stick, and that's only if there's like an identifiable bleeding point, then that's when we would do nasal cautery. And it's really important to only cauterize one side of the septum. If you do both, then you might risk perforating the septum. So yeah, first line is basically like first aid measures. Then second line would be the nasal packing. And you can also kind of put ice on the front of the nose to encourage the blood vessels to what's opposite of dilate, to constrict. So yeah, that's epistaxis. And then we're on to the last question, which is a 56-year-old male presenting with a 2-week history of reduced sense of smell and facial pain, especially when leaning forwards. And what is the first line option? Okay, next slide, please. So if we go to the next slide as well. So this patient likely just has like simple rhinosinusitis. So he's just going to need nasal decongestant. So that's something like xylometallazone. But when patients present with, so normally that can just be like managed by primary care. But if people kind of have like worsening symptoms, so symptoms aren't getting better, or symptoms that initially get better and then get worse, it's like a biphasic presentation, or who, like, say they're like systemically unwell or immunocompromised, then they're the patients that will need antibiotics. So the main key symptoms of rhinosinusitis is like nasal congestion, so like nasal discharge, facial pain, like typically like on the forehead and under the eyes is like a common one, and like tenderness when you press over the sinuses. The most common bacterial causes would be Haemophilus influenzae and Strep pneumoniae. But yeah, it's just quite important to differentiate between acute versus chronic. So acute is just kind of like about 4 weeks, subacute 4 to 12 weeks, and then chronic is when someone has symptoms lasting longer than 12 weeks. And you can get like acute on chronic as well. So if we go to the next page, so for someone that you think need antibiotics, so that would be like kind of longer symptoms persisting longer than 10 days, red flag symptoms like fever, or very, very severe pain, then they'll probably need phenoxymethylpenicillin. And then nasal decongestions, so that was in the question, and that's something like xylometazone, but it's important not to prescribe the nasal decongestants. It's prescribed for a week, and then they need to stop after a week because sometimes patient can get rebound symptoms of the rhinosinusitis. So it's important to like explain and safety net to the patient just to use it for a week and then just to have a break afterwards. So yeah, that is everything.
Well, thanks so much, Emily, and thanks for everyone who's attended. I am just putting the feedback link in the chat, so if you just please fill that in whilst Emily's here. If you have any questions about ENT, she can answer those. But otherwise, thank you so much for attending, and we will be posting this recording on our YouTube and website as well, and we will have this on our Medall as well. So many different ways of accessing this. So yeah, please fill in the feedback, and thanks again. Yeah, we'll hang around for a bit if there's any other questions, but if not, feel free to enjoy your evenings. Okay, looks like there aren't any questions that I can see. But yeah, keep filling in those feedback forms. And yeah, this is just a little reminder of our ways that you can get in touch with us and /see content. The other thing to add on here is the YouTube. So if you type in medtech teaching on YouTube, you should be able to get our YouTube as well. All right, well, if there's nothing else, no further questions, we'll probably end the session here then. Just keep filling in those feedback forms. You can still fill it in even after we've discontinued the streaming. But yeah, have a lovely evening, everyone. Thanks again.
Bye, thank you. Thanks, Vex.